Thank you, Dr. Leibowitz, and I hope all of our remote speakers will remain on the phone because we do have questions from the committee, I believe. I'm going to exercise my prerogative and ask the first question for Dr. Leibowitz. We're very interested in the insurance coverage issues because that's come up. Our patients have articulated this as a problem today and yesterday. And I want to come back to one of your slides, the first slide in which you introduced the CPB for temporomandibular disorders. There was a statement that said, for plans that cover treatment of TMD and TMJ dysfunction. And that would imply that Aetna also writes plans that do not cover TMD and TMJ dysfunction. And I'm also aware that there are other insurers that also write plans that do not cover TMD and TMJ dysfunction. Can you articulate that a little bit? Because I think that creates an obvious canyon in coverage for folks. And I think that the second part to the question is, do you have any thoughts on how, as a healthcare insurer, how do we solve this medical and dental coverage divide? What might we think about doing as we move forward? Sorry about the complicated question, but
no, that's fine. Well, essentially, it is a complicated question, and so I'm going to remind you that I'm talking mostly about commercial coverage. Okay. So when you're talking about Medicaid and you're talking about Medicare, we follow those guidelines, and what they use is Medicaid uses Norman guidelines, and Medicare has its own LCDs, NCDs. As far as coverage, whether we cover TMD or not, in our commercial plans, this is largely self-funded. It's self-funded by large corporations. The companies that buy our plans they are the ones that create what benefits are going to be in the plan. So that is essentially what that is referring to. Most plans do include coverage for this, but the employer who buys the plan may or may not decide to cover TMD, and I think that's basically what the issue is. We have no position our position is we'd like to cover TMD every time, and that's usually what happens. But the fact of the matter is the plan sponsors are the ones that choose what the benefits are for each plan. I don't know, did that answer that for you?
Well, I think that's under ERISA that permits that, but I'm not sure that ERISA, I don't think that allows employers to not cover anything they choose, does it? There
are things that they cannot cover. It doesn't allow them to not cover everything they choose, but they can exclude TM coverage. Other coverage that's frequently excluded is sometimes chiropractic, also developmental therapies, and things like that. Now, your second question was, what do I think we can do to close that gap? Well, the real issue is really a larger issue. The real issue is, how do we get the right care to patients with chronic pain? And we're not doing very well as a country in this. And so we would like to do some interdisciplinary pain care, and it's probably appropriate for a lot of patients, particularly if they've had TMD for a long time. But as you know, there's less than 200 centers in the country. And also, as far as interdisciplinary care, specifically for TMD, I'm not aware of those centers, but I once again suspect that there aren't too many treatment centers there. So we've had, for example, that CPB that I showed, that I mentioned, a chronic pain program with states that would cover interdisciplinary care. And after that was passed, I thought this would make the difference, but it's really not that. It's that we don't have providers that know to appropriately refer for correct pain, and they don't know what to do with this. And as Dr. Chen mentioned, we, in some cases, dentists are not necessarily seeing the patient as opposed to a medical physician. But once again, that is largely governed by what the state laws say as far as equivalent providers. So, are there any other questions?
No, I think we want to go to Dr. Durham, who has a question from the UK, and then Dr. Vickery has a question here from the committee.
Thanks, David. It was more to comment on Dr. Levovich's last comment, which was that he thinks it's difficult to identify the different types of patients that there might be, the different experiences that patients might have that need to go into more pain management or those types of approaches. And it goes back to Dr. Barad's comment around pain management clinics. I think there's a very simple way in TMD of doing that, and it's 7 questions long, and it's called the Grady Chronic Pain Scale, and it's been around since 1992. It's stood the test of time, and we've shown that it will stratify patients into either a high-need group, i.e. those who will need expert specialist provision earlier, and a low-need group. And it's very simple to use, and it's standard practice in most orofacial pain clinics to use it. And actually, one thing this committee would probably have well within its power would be to suggest or mandate that it should be used, because that would be a stepping point and a starting point for primary care physicians to at least pick out who's in extremis and who is not. And that doesn't mean that they should or shouldn't get care, but the lines of care that they might follow might be different. So, for instance, a low disability reading on that scale would probably mandate some simple initial treatments within primary care, within the community setting, from a general medical practitioner, or as you call them, family doctor.
Thank you. Dr. Vickery?
Yes, I have 2 questions for Dr. Ness, and I was struck, Ms. Van Enneveld gave a really classic example of why we're interested in patient-reported outcomes in addition to the more traditional outcomes that clinicians focus on. She said, my pain was worse after the procedure, and the surgeon said, but the radiographs look great. So one question, Dr. Ness, you'd mentioned that there are maintenance of certification opportunities for the profession that report outcomes in terms of efficacy, and what for those that can provide that with related to these kind of procedures, what kind of efficacy outcomes are included? Let me get my second question in, because you may cut me off if I don't. The other is, you were commenting about you could go look online and see claims about being able to manage this. You used the word quackery, right? You did use that. And I guess that I wonder, is there any monitoring of advertisements in the profession, either externally, or does the professional society have some criteria, or are they concerned about this in some way and have a policy on acting on that?
So thanks. Two issues. The first question about maintenance of certification really relates to board certification for oral surgeons, and it's really, actually the process just changed, so we're about to discover what it's really like over the next few years. But that's not although there is a component of outcome assessment that's required within offices, but it's not specified what you measure. For a lot of oral surgeons, they might be looking at how their third molar patients do versus, so certainly that's an opportunity if one so chooses to look at TMD outcomes, but there's nothing that would mandate that necessarily. To your second question, no, it's very difficult to police this. Much like what the orthopedic surgeons found, dental boards on a state-by-state basis can censure dentists for making inappropriate claims, but they're very reluctant to say, well, your science just isn't strong enough, because that puts them in a position of adjudicating the science, and they don't like to have to do that. It would be, I think, very important for someone to do that and give them a basis for decision making.
Dr. Bullock.
It's okay. I was making a mistake. Thank you. If I could make a point and then have a question for Adriana, one of the things that she mentioned, which I find disturbing to say the least, excuse me, is that when you get to a point where the surgical intervention has not been productive, the abandonment that seems to go with that. That's not something I experience at Emory because we work so hard to put you into an appropriate environment with chronic pain specialists who we work with. And I would consider not doing that to be below standard of care, and we really probably need to address that in the care pathways so that there is a backup plan, and we always have a backup plan for those individuals, as it should be the case. The other thing, again, the volume of surgical procedures that an individual goes through portends to a really poor outcome, and I suspect that means a really poor diagnosis made initially. The general rule that we adopt, and I think most of us, Greg included, and most of the ASTMJ and AMOS members who do academics, would be, from an open procedure point of view, you may have one open procedure if you've failed arthroscopy or arthrocentesis, and if that procedure is not successful and the diagnosis is still deemed to be appropriate, as in you reevaluate to make sure you don't misdiagnose, there isn't some other issue going on, you really get one more bite at the cherry, and that's about it. Once you get to the second surgery, it better be the right surgery, because the third, fourth, and fifth, and sixth are just not going to portend well. And we know that. We've known that for a long time. So, you know, it's still a sad indictment on what has happened and what's transpired, because at that point, then there's a disconnect between patient expectations and the reality of what can be achieved by the fifth or sixth surgical procedure. And it needs to be a very honest dialogue, and that's clearly not occurring. Thank you. Yeah, so a comment to the committee and maybe a general question to AAOMS related to care pathway. I think we would all agree that our care pathway is in shambles. It's totally chaotic, not only for patients but also for clinicians. So a patient has difficulty in entry, deciding where to enter into the system. The primary clinician who sees patient has difficulty on determining where to refer a difficult patient. The tertiary care centers where there's a failure in treatment has difficulty in determining next step, leading to either intentional or unintentional abandonment. So all the way along the system, there is absolute noise and uncertainty into care. And I'm curious whether a process by which individuals enter into required conservative therapy in a multidisciplinary setting prior to a referral to invasive surgery, trying to keep that tip of the iceberg very low, should not be mandated for triage of patients prior to being seen in any surgical specialty at this point in time. And I'm curious on AAMOS's opinion on whether a front-loaded triage process, conservative treatment, multidisciplinary, would be tenable rather than direct referrals for first-time assessment by good and bad surgeons.
That's a great question, and you just pointed out another thing. I mean, you know, that our pathways have a series of hard stops where you can hit the brick wall that we've heard about from our patients. Here I'm going to be a splitter again just a little bit because it's too hard to speak in generalities. Because if a patient has synovial chondromatosis, there is no amount of non-surgical therapy that is going to make that go away. So we need to take those off the table. Having said that, if a patient has the painful popping, clicking joint, if you read really quickly with the Aetna slides, they mandate 3 to 6 months of non-surgical care before they'll approve a procedure for that. So, and we're not opposed to that. I think those of us who do this do not want to operate earlier. In fact, if you look at, and unfortunately we don't have hard data on this, but if you talk to enough surgeons who do TMJ surgery, you'll find that among the patients who were referred to them with the expectation that they may well need an operation, probably less than 20% have any sort of invasive treatment, and for half of those, it's an arthrocentesis. And we actually operate on a very small percentage of the people who come to us expecting to need surgery. That's kind of fun because I get to tell the vast majority of people I see the day I meet them, you don't need an operation, and they're always really happy. So I get to be a hero, at least for a few minutes. Now, the downside is I don't have an instant cure for you. You need to go see Dr. Frickton or, you know, the people who can handle your more complex problem. But yeah.
Just one quick follow-up. So, and I'm a little bit out of the loop on this, but does AAOMS support the initiative for a orofacial pain specialty through the ADA?
I don't know the answer to that. I don't know that there is a formal position on that, to be honest. But that's certainly something we can find out.
So I have a question for Dr. Livovich from one of our workshop participants, and the question is about insurance coverage for arthrocentesis and some of the other TMD treatments that may have been in your policy, your CPB, with limited or no evidence base.
I'm sorry, I didn't hear the end of what you said.
Oh, okay. So the question was around coverage for arthrocentesis and some other TMD treatments for which there is a limited or poor evidence base.
Okay, what's going on is I'm getting some kind of crosstalk here. So you want to know about coverage for arthrocentesis, I think is what you were speaking of, correct?
Yes.
Okay, what specifically, because as far as arthrocentesis goes, I don't have a lot of personal knowledge about it. That's why I brought the clinical policy bulletin. But if you have a specific issue, I can take it back to our council. What is your issue? All right, I'm not hearing very well.
Yeah.
But I know that. Go ahead.
I think to summarize, the participant is taking issue with your coverage for invasive procedures for which there is believed to be little or no evidence base.
Okay, so what I can do with that information is to bring it back, and I would love to get the feedback from the committee. We try to keep these up to date, but if we're providing coverage for something that's really not evidence-based, we take that feedback and we can make that change.
Okay, Richard.
Yes, I have a question for Dr. Ness. You seem to emphasize that training is one of the keys, and to which I agree, of course. With that, and just as a follow-up to Bill's question about specialty recognition, and I will differ in my question from how Bill phrased it, which was an AAOMS specific position. It seemed that you personally emphasized and agreeing with Jim Frickton's push, on specialty recognition for orofacial pain, and I'm just wondering if you could elaborate on that.
I'm not sure I can elaborate in the time available because that's a complex issue that's framed by political, social, educational issues. But maybe the really short version is that we're at a point in dentistry where, and medicine crossed this line a long time ago, where specialty recognition is, and what it means to the public is changing rapidly. Right now, there are a variety of different ways a group can become a medical specialty or call itself that. Historically, within dentistry, that's been much more tightly controlled. At the same time, we have some changes at the ADA to how specialties are recognized, We have changes in law as to what specialists can or can't do outside of their specialty, changes in code of ethics on that, and we're starting to see sort of a blurring of the line of what is a specialty. Those are the things that feed into whether a group might like or not like the idea of adding more specialties. My personal opinion is that where there is a well-defined, credentialed course of educational preparation available, that seems like, in most cases, there's a reasonable basis for a specialty to exist. There are other criteria as well. Orofacial pain, in my opinion, meets that important test.
I think we have time for one more question. So, Adriana?
I don't think it's any of our intention to paint all surgeons with the same brush, and absolutely there are success stories out there. But those of us that moderate these support group pages and inspire communities, I mean, we hear from thousands of patients, and as encouraging it's encouraging to hear that not all, that there are surgeons out there that take a very serious conservative approach, but to be sure there are surgeons that do not. And so my question is, who regulates? Is there anyone watching and noticing who's continuing to operate too many times and put a stop to it?
That's an excellent question, and the reality is there is no control. We have little control to an independent person. So I think developing some guidelines and care pathways that sort of intimate very clearly that there's X number of surgeries and these are the sequences that should be followed for the majority of pathologies. And if we're talking just TMD, so internal derangement, degenerative joint disease, not the tumours and cancers, then I think we need to help create that document and shape it so that people understand. And most of us who do a lot of it know very clearly, but obviously there's a group of aggressive people that we need to not shame, but just guide, I think, and cajole into a more appropriate way. And we can do that, I think, through AMOS and through ACOMS and ASTMJ, because nearly everyone's going to be a part of those three groups.
All right. Well, I'd like to thank all of our panel, and as with what we concluded yesterday, it's evident that we have quite a bit of work to do. So I'm going to turn this back over to our committee co-chairs, and I believe we have some more speakers.